Hello, everyone. Welcome to our series and our presentation today. My name is Dr. Janine Cross. I'm Associate Professor for Howard University School of Social Work. My background is in maternal child health with emphasis on maternal mortality, health disparities as it relates to the perinatal population, as well as how to support vulnerable and fragile infants. I'm also the co-PI on a SAMHSA grant called HUMHAS, which is the Howard University Mental Health Awareness and Suicide Prevention Grant. And we are doing this training today as part of our series of mental health awareness trainings. And I am lucky and happy to be accompanied today by a doctoral student, or doctoral candidate, excuse me, Unique, Unique Williams, and I'll let her introduce herself and also let you know a little bit more about her research interests and background.
Thank you so much, Professor Cross. It is amazing and great to be in this space today. My name is Janique Williams Adeniji, and I am a third-year doctoral student slash candidate at Howard University Social Work Department. My research and passion is on the maternal mental health care among African American women, specifically the barriers that exacerbate the underutilization of care, which we are now understanding that is on the forefront and of almost everywhere, the necessity of perinatal persons to have great care. Mental health care is one of the most important things that a pregnant person can have while having a baby, and of course, even after, which we sometimes forget because we sometimes forget that moms need a space just to kind of process what that looks like to even bring life into this world. So I am very excited to be here with Professor Cross and everyone here as well.
Thank you. And so now we're going to move forward with our presentation. Can we upload the slide presentation so that we can begin? Thank you very much. And so today, again, we're going to cover maternal mental health with the goal of understanding important factors that go into maternal mental health. I'm going to talk a little bit about screenings as well as treatment as well today. Thank you. So before we can have a conversation about mental health, we really need to at least do a deep dive and really talk about some of the major issues that are plaguing what are some of the trends that we're seeing in perinatal populations, with emphasis, of course, on vulnerable African American populations and other vulnerable populations, and that can be related to socioeconomic status and environment as well. So when we think about what are some of the challenging facing pregnant and postpartum women, what is it that you think about? Please think about some of that while we move along the slides. One of the big areas of concern in our society is the mortality rate. Currently, the U.S. mortality rate is 20.7 deaths per 100,000 mothers. In the District of Columbia, where we're located, the mortality rate is 23.1 per 100,000. And 70% of those deaths occurred in the DC area. And in the specific area where most of the deaths occur, where we had the highest poverty rates here, which is Ward 7 and Ward 8. And also that mortality burden was experienced mainly by African American populations. Black mothers represent 50% of all births in DC, yet comprise 90% of the pregnancy-associated deaths. And so even though we're providing some of the statistics that are specifically in DC, maternal mortality is a huge issue in our country and globally as well. And so again, that's one of the main areas that we focus on, and what we are seeing in terms of some of the concerns that we have for our perinatal populations. Another area of concern in terms of our perinatal population is infant mortality. Non-Hispanic Black African Americans have 2.3 times the infant mortality rate as non-Hispanic whites. We also know that non-Hispanic Black African American infants are 4 times as likely to die from complications related to low birth weight as compared to non-Hispanic white infants. Non-Hispanic Black African American infants had twice the sudden infant death syndrome rate than non-Hispanic whites, specifically in 2018. And in 2018, non-Hispanic Black African American mothers were twice as likely to receive late or no prenatal care as compared to non-Hispanic white mothers. So we also have a concern as it relates to infant mortality, maternal mortality and infant mortality. We're not doing good in our country in terms of those two areas, and it's something that we're trying to improve upon. Substance use, another huge concern in perinatal populations. A 2019 study of pregnant respondents disclosed prescription drug use during pregnancy, with 68% receiving counseling about the effects of prescription opioids on infants. In this study, 21% of respondents admitted to misuse, and these are pregnant persons, and 27% expressed a need or want to cut down on their prescription substance use. African American and Latinx respondents were overrepresented in the prevalence of prescription use at 8.6%, 7%, and 5.9%, versus the 5.9% of white respondents. Again, so we do know they're also seeing an uptake in terms of substance misuse in perinatal population, as well as addictions as well. Can't have a conversation about substance use without talking about neonatal abstinence syndrome. Between 2016 to 2020, there was an 18% decline in the estimated national rate of NOS, and the estimated national rate of prenatal substance exposure increased approximately 4%. In 2020, the state level neonatal abstinence syndrome rate ranged from 3.2% per 1,000 births, which was Hawaii, up to 68 per 1,000 births, West Virginia. So what we're seeing is that overall nationally, the neonatal abstinence syndrome rate has declined, but there are huge fluctuation and swings when you look at the state level data. And so states such as Hawaii show more lower level neonatal abstinence syndrome rates, where states more areas such as West Virginia are showing a lot higher rates. Between 2016 and 2020, 28 states experienced a decline in neonatal abstinence syndrome births, and 20 states had an increase in NOS rates. Also in 2020, the lowest prenatal substance exposure rate was observed in New Jersey at 9.9 per 1,000 births, and the highest in West Virginia, 88.1 per 1,000 births. Between 2016 and 2020, 38 states experienced an increase in the rate of prenatal substance exposure, and 10 states experienced a decline. And hopefully this slide really does a good job highlighting our concerns as it relates to our trends in substance use populations, or when we speak specifically about perinatal populations. And so we also have a growing problem with substance use, which is requiring infants to have to be admitted into specialty care, such as newborn intensive care units, because they're withdrawing from substances. One of the things that we do know is that we're also seeing an increase in incarcerations for pregnant as well as our parenting women. There's a mass incarceration of women, and we know that some of this is due to the punitive responses specifically to mental health and substance use disorders. In short, women are being incarcerated mainly because of mental health and substance use challenges. Prison, we also know that there are certain policies related to imprisonment and incarceration that further puts pregnant women at risk. For example, prison shackling policies, where oftentimes mothers are shackled when they're delivering babies and also receiving prenatal care. And we know that this is a very dangerous practice, putting the health of the mother as well as the infant at risk during this time. We know that it's dangerous because it limits the mobility and the balance. It increases the risk of falling, which can increase placental abruption, hemorrhages, and stillbirth. We also know that it increases the chances of blood clots, and also shackling interferes with the medical provider's ability to provide appropriate care, which is standard care and or emergency care. Some of the concerns that we have here is that a criminal justice response is being applied oftentimes to women who have mental health and substance use challenges. What we know also is that prisons and jails are not the appropriate places for pregnant and incarcerating for pregnant women, mainly because they are not equipped with the ability to provide appropriate standard health care. Women do not receive appropriate prenatal care or postpartum care during the incarceration process. So again, we have plenty of challenges in our population. And in order to really go into some of the concerns that we have in terms of mental health, we really need to understand what are some of the main social issues that are plaguing this population. Hopefully at this point, you're starting to get a sense of how mental health can play a role when pregnant women or perinatal populations have to deal with the level of social issues. These are serious issues. When you have to worry about not receiving proper care as you go through your prenatal course, when you have to be afraid whether your providers are going to listen to you, whether you're going to have a safe pregnancy, will you actually be alive through the duration of your pregnancy? Will you have complications with your delivery, or will you have complications postpartum? What we know is that women are at risk prenatally of dying. They are at risk at delivery, and then they're also at risk at postpartum for maternal mortality. This can weigh mentally on someone. The stress, the fear, the worry about their life and their ability to be able to survive a pregnancy. Another concern, again, is now your infant's life. You know, if I were to deliver this baby, am I going to deliver a healthy baby? Will my baby be premature? Will my baby be low birth weight? Or is infant mortality a concern for my unborn child as well? And we also know that African American women have higher rates of low birth and preterm infants as well. Due to substance abuse challenges, oftentimes women are not getting the appropriate care. They're not being screened, and they're afraid to admit when they have challenges with substance use. Oftentimes because they're afraid that a child welfare approach was going to be taken, meaning that due to mandated reporting laws, mothers will be reported to child welfare due to substance use. And oftentimes they're afraid to have that discussion on substance use, whether they are struggling with it and want to stop. There are resources, there are programs available, but there's a consequence to sharing that. And that substance use can also put that woman's life at risk and her infant's life at risk as well. And it increases the chance of mortality for her and the infant. But oftentimes they're not getting the screens that they need, and even when they are screened, they may not be honest because of fears of a punitive response. Again, as I stated earlier, the other concern is that sometimes women are not being treated properly for mental health as well as substance use issues. And oftentimes we are utilizing criminal justice responses to deal with these issues. And what we also know is when women are incarcerated, it further exacerbates trauma. So if they have a history of trauma and then they're also incarcerated, that also provides another layer of trauma that they may experience as well in prison settings. What are common mental health challenges for pregnant and postpartum women? And are these mental health challenges prevalent? Think about that as we cover the next few slides. In terms of depression, there was a study done between 2010 and 2020 in Southern California. In that study, there was approximately 442,000 mothers who were at 20 weeks gestation and above. Um, this particular study showed that approximately 14% of those women had a prevalence of perinatal depression. Prevalence increased in all racial groups. So there was an increase in perinatal depression for whites, Hispanics, Blacks, as well as Asian Pacific Islanders. But what we saw specifically in the numbers are that the white women reported about 14 to 22% prevalence in perinatal depression. Hispanics reported between 9 to 19% incidence of perinatal depression. Blacks respondents reported about 9 to 22% of perinatal depression, and Asian Pacific Islanders reported 4 to 14% prevalence in perinatal depression. What was also interesting about this study is that this was observed in all BMI categories and high rates of obese and morbidly obese women. So even in accounting for obesity rates, there was still a high prevalence of perinatal depression. Here's another study that also gives you an idea of the prevalence of anxiety in perinatal population. About 1 in 5 women experience symptoms of anxiety. That's the same rate also for depression. We see about 20 to 25% women experiencing depression. 15 to 21% of women actually report having anxiety. We also know that anxiety as well as depression can occur at any point during the perinatal period. This can be prenatal as well as postpartum. What we see in a lot of our studies are that women can be symptomatic and be diagnosed with depression up until 1 year of life for their infant. And this has special implications when we're thinking about screening as well. Risk factors that are included when we think about anxiety is during pregnancy is the labor and delivery process and having a baby with health challenges. So oftentimes women are anxious and nervous about specifically the labor and delivery process and concerns about the health of their unborn child. If you think about some of the trending social issues that I talked about in terms of maternal mortality, infant mortality, and some of the concerns related with that, it becomes a lot more easier to see why anxiety is a prevalent concern diagnosis for women in the perinatal population, in the perinatal period. Need to at least identify this because it's very important, very dangerous, postpartum psychosis. Even though the rates aren't as high, about 1 to 2 out of 1,000 women will experience postpartum psychosis. This is a serious concern because the mother's safety and the infant's safety are at severe risk at this stage. It is considered a serious medical condition, and it's also considered a mental health emergency. Immediate medical treatment is needed when a mother is diagnosed with postpartum psychosis. Oftentimes, mothers are often misdiagnosed and do not receive proper mental health care for postpartum psychosis. So again, it's not a highly prevalent condition, a mental health condition, but it is one of the most severe in terms of the consequences to the mother and the baby. And so we need to be very vigilant of all mental health challenges and make sure that we're screening properly, particularly for depression, because what we don't want is that untreated depression to transfer into postpartum psychosis or any untreated mental health condition in the perinatal period. PTSD, approximately 9% of pregnant women experience PTSD. Panic disorders occur in about 11% of new mothers. Some of the concerns are interpersonal violence are the risk factors, traumatic delivery, natural disasters, life-threatening experiencing or witnessing life-threatening experiences, which is particularly of concern for our mothers who reside in high crime, violent areas. The chances of having life-threatening experiencing or witnessing life-threatening experiences increases in certain communities of low socioeconomic status, poverty communities, and again, those communities that have higher crime and victimization rates. There are also particular concerns for women who may have an infant who is admitted into the newborn intensive care nursery. Women who experience a NICU delivery or a delivery and their infant ends up in the NICU has an increased chance. It puts them at a higher risk factor for depression, higher risk factor for anxiety, and we're also seeing higher levels of PTSD, either related to the traumatic delivery, having a preterm birth, and or the traumatic experience of having a low birth weight infant in the NICU. And this could be related to seeing that infant in an isolette, on breathing tubes, low birth weight, premature, fighting for their life daily. Sometimes that is very traumatic to see all that, those tubes hooked up. And also being on edge every single day, not knowing from day to day how well your baby is going to do or whether your baby is going to make it. That's also traumatic in itself as well. And also it's important to mention here that even though this particular presentation for Maternal Mental Health Month is focusing mainly on mothers, we would be remiss not to have that discussion about fathers as well. Mood disorders during the perinatal period also occurs with fathers, and we also need to make sure that we're doing our due diligence to screen partners as well. And these are screens for depression, as I mentioned, anxiety. We want to also screen for PTSD, panic disorders, all the above, and make sure that we are more vigilant during that perinatal period, not just of our mothers, but also of our fathers, to make sure that they're getting screened and also making sure that they're getting the treatment that they need. And I'll hold off right here, and we're going to now talk a little bit about the DSM, and I'll hand it over to Yannick.
Thank you, Professor Cross. So to start with the DSM, and just to get a deeper understanding of these disorders that Professor Cross spoke about, it is important to understand, more about the diagnosis, especially what that looks like when you are pregnant or you're in postpartum. Major depression disorder, which has a specifier for peripartum onset, is applied to the current depressive order. It has an onset of mood symptoms, which occurs during depression or within 4 weeks or even after delivery. It is important to note that 50% of postpartum major depression started prior to delivery, which is so important because when we think about postpartum, we think that it happens after you gave birth. But really, 50% of women who give birth, they actually could have faced or are at risk with depression during their actual pregnancy. And even though Professor Cross just said, even though the psychosis piece is very, it's not high, it can present itself with or without this feature. When we look at the prevalence of major depressive disorder in the US alone, depressive disorders appears to be higher among African Americans and Caribbean Blacks when compared to whites and even Hispanic. And there's also a multitude of these things, which I'll get into a little bit later. When we look at anxiety, the prevalence overall, 2.9 adults in general community of the US actually suffer from anxiety, though women and adolescent girls are at twice as likely than men and adolescent boys to experience general anxiety, though the mean age of anxiety is 35 years old. It can appear at any point in your age, and that is true within your pregnancy. Anxiety can show up when you first find out that you're pregnant. It can be at any trimester or even after delivery, depending on what kind of support you have, who is around you, and even just the environment where you're at and what kind of stressors you have been dealing with prior or even during your pregnancy, whether that could be finances, that could be support, it could be if you're a single parent, or even in being in relationships that are together, you are with someone, it still can provoke anxiety. And so what it has been found in the US, persons who have been exposed to racism and discrimination are at a higher level and a higher risk to experience anxiety, particularly when they are pregnant, which we know women who of color, they sometimes experience different mental health care access, even just getting particularly just care in general can provoke anxiety. So unfortunately, the rates of anxiety remain very low when we think about putting anxiety in remission. When we look at PTSD, PTSD can show up anywhere depending on what a person has been exposed to. The prevalence nationally, the lifetime for PTSD is at 6.8%. It remains very high among African American and Latinx persons due to racial and discrimination, and of course disparities when we look at health. So PTSD, it is more, unfortunately, more prevalent among women in general when we think about men. And this can be attributed to so many different things. As a woman, unfortunately, we're more vulnerable for sexual abuse, assault, interpersonal violence, and also it has been seen within the DSM that women who also struggle with PTSD, they deal with the symptoms much longer than men. And when we put it in the context of pregnancy, as Professor Cross elaborated, there's so many things can happen during pregnancy, up until you're taking your baby home, that can exacerbate PTSD. So many times women can have a perfectly 8 to 9 months with just everything's going great. Everything is wonderful. And then you look up, the water breaks or however it happens, you're in the hospital, and then you have to do a emergency delivery, which was not planned. And so that can exacerbate these symptoms. Next slide. So when we know all of these diagnoses and we know that it's just a huge prevalence of mental health disorders when a person is pregnant or after, it is important to understand the risks and the barriers to care. One of the biggest barriers is limited access. And when we look at limited access, it can be so many different things. One, insurance. Though we have not universal care, but we have Medicaid, private insurance, we have to think about, what about immigrants? What about pregnant persons who are homeless and they do not have their insurance paperwork, or they're not able to have transportation to go where they have to go get mental health care. When we think about costs, even we're in a space where there's that they call them desert hospitals or clinics, where you live in a rural place and the next clinic is 2 to 3 miles and you don't have a car, or there's no buses, or you may have a phone but your Wi-Fi is not working. COVID has showed us that we can have appointments through telehealth, which is great, but if you don't have service on your phone or you have not paid your bill, then how are you going to have a session to talk about whatever you're going through? Another big one is stigma. This is across cultures. That is this idea of being a mother, that you're not supposed to be you're not supposed to be unhappy when you have a baby. You are supposed to be excited. You are not supposed to be crying. There is just this stigma that you should not talk about the things that you're going through, because it's no longer about you. It is about this new, beautiful life that you just brought into this world. Um, Secondly, there is, depending on your race, or if maybe you have had a bad experience with the healthcare system, there's this mistrust about just being vulnerable, talking about your feelings, what you're going through as a mother, or even what you're going through with this pregnancy. Sometimes, even within healthcare, there are provider biases, where whether you are poor or whether you are upper class, there's just this stereotype of what a person shows up as, which sometimes breeds mistrust on both sides of the coin, whether it's the pregnant person or the provider. And then, of course, there's always discrimination. There's also fewer access to specialized trained clinicians. And this does not mean that they're not good clinicians. But what we know is pregnancy is in itself is a changing event. We understand that you can be trained as a therapist in depression or OCD, but when you are dealing with someone who is pregnant, it comes with hormones, it comes with so many different things that birthing persons go through, that maybe the clinician who is not truly trained in this area, not to say that they can't help, but it may not be the best fit. And then, of course, we did hear Professor Cross talk about poverty is a huge, and will continue to be a huge gap, a barrier to mental health care. Poverty means so many different things. It means lack of education. It means lack of access. It means lack of understanding. It means that you sometimes have to put yourself in the back and take care of so many different other things and different people. A lot of people who are in poverty, they have other stressors in life that are more concrete than to sit down and talk about their own personal things for 45 to 50 minutes. And then finally, just the lack of education around perinatal mental health. It is a thing, it is an important thing that so many people don't talk about, because it's almost this, like I said, with the stigma, with the mistrust, there is this idea that we should not talk about it. So therefore, people don't seek education. And then depending on where you live, education is not easily disseminated. So I would be remiss to discuss the impact of COVID-19 on birthing persons. As we remember, pregnant persons overall were placed in the highest category. This is important to me because I was pregnant during COVID-19 with twins. What we knew is that during the pandemic, mothers experienced elevated levels of depression. In 2020, cases of depression almost doubled from 19% to 35. We see an elevated level of anxiety, postpartum stress disorders. Imagine being pregnant and depending on where you were given, what time of COVID you were given birth, certain people could not come into the delivery room. Women were not able to that first appointment with the OBGYN, partners were not able to come in. There was just like this angst that something was going to happen. Women were almost put in a bubble where people could not come visit you. You could not visit anyone because this was even pre-vaccination. So what did that look like? Many people were unable to do baby maternity shoots. People did not have baby showers. And then essentially the whole world itself, we were on lock. So you were just isolated, which was a different experience. The fear of COVID-19 complications. Many women who were pregnant, there were early labor, there were respiratory issues, there were hospitalizations, and most important, there was the death. There were women who had COVID went during labor and they didn't make it out of labor. There were women who went into the hospital COVID negative. And by being in the hospital, they wound up getting COVID. And so they were separated from their babies. So there was just so many different things. So it is important, even though where we're at with COVID, it is important to just understand that deep impact that happened. And then when we think about COVID-19 producing moments of postpartum depression, we know that postpartum depression affects not just the mommy, but the mommy and the baby. So maybe there's toddlers right now who are 2 to 3 years old, but that attachment may be different had there not been COVID without postpartum depression. So this is just a little more information about COVID and what those stress factors look like. There was uncertainty about the effects of the virus on the mother, the delivery of the baby. There was social isolation, as I just spoke about. There was this fear of joblessness, because we remember so many people either lost their jobs, and we know that there were a lot of pregnant women who were essential workers, and then there were some who were not, and that goes back to depending on your social economic status. If you were pregnant, you could have lost your job, or you had to work. So it was either your health and your baby's health, or paying for your rent. There was a huge increase of domestic violence, difficulty to access police or protective structures, and it was indicative if you were pregnant or not. And we see all of those things exacerbated anxiety, depression, PTSD. In a response to pregnant women about the percentage of negative impacts of COVID-19 and their stress, this was a chart from a research. What we saw was a lot of the things that were important they dealt with alternative transportation. So when we think about how were they going to the doctor, how were they socializing? Then there was women in general. I was one of them. I avoided all socializations because I was scared. There was you try to avoid large social gatherings because that is what the TV told us every day. Remember, 6 feet, social just distance. Everywhere you go, you saw these stickers everywhere. Sometimes people would look at you like something was wrong with you if you even sneezed or breathed. And then you're pregnant and you see that, how would that freak you out? Then there's self-isolation, where even remember when things started to kind of open up, where you could be in a group, but it could only be 50 people or 40 people or 15 people or however, but some people, mostly a lot of women in general, said, I'm not going anywhere. Even though they say it's okay, I'm not going anywhere. And when that in itself, that's part of anxiety, just this worry that if I step out of my house, something is going to happen to me and my baby. There was finally just working from home. A lot of people worked home. That was just the new norm for everyone. But women who were pregnant or birthing persons, they had to work from home. But what we know is that sometimes they could have had other children in the home. We didn't even know how everyone's house was different. What did that office space look like? How did they navigate, right? So you have all of those different factors happening that could definitely impact the mental health of a regular person, but someone now who is giving birth or is on the way of giving birth. So with that said, which is something I'm very passionate about, is why is screening so important? So one, screening is important because when we have timely, routine screenings, early intervention equals early treatment. It is a point of education. During a screening, that is where you're able to ask questions. People are asking, questions that are asked of a birthing person that may not be asked in different spaces. It prevents worsening of symptoms because once you're screening, we hope that you would now get support to go to get treatment. So someone who has anxiety, right? A lot of women who deal with postpartum anxiety, right? Imagine having a baby and you think something's gonna happen to your baby all the time, that you're always getting up, that every 15 minutes you're checking the baby all the time, all the time, all the time. With screening, you're able to kind of figure out, like, how can I manage this symptom? The importance is birth and postpartum planning, because, when you think about breastfeeding and medication, patients are connected to mental health services sooner than later. That is always important. And then you're able to get quicker referrals for community resources and clinical services. So when we're looking at screening tools, the parental stress scale, which is the PSS, is an 18-item questionnaire assessing parents' feelings about their parenting role, exploring both positive aspects and negative aspects of parenthood. So this is important because, like I said earlier, sometimes people are ashamed to say there are negative things about being a parent. And sometimes people don't even realize that they were going to have negative feelings about being a parent. People think that it's always sunshine and laughter, and sometimes it's not. A baby crying every hour on the hour at 3 a.m, that's not negative. That's not positive, especially if you haven't slept. Tools used, it's also used to assess outcomes of interventions designed to support parenting efficacy of parents, fathers, and caregivers of children across a wide age range. So that is important. We need to really understand the importance of bringing in the fathers and the other partners, right? When we always think about it's all about mom, 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 but mom also needs support. And if dad or the other provider or caregiver is not in the best space, how can they now support mom when she's going through her own mental health issues? So it's all connected. And then it has really good internal consistency and good test retest correlation, which means that it has been tested and retested, and we know that it works. So the gold standard, which we know is the Edinburgh Postnatal Depression Scale, it is used in everywhere. It is a 10-item questionnaire originally developed to assist in identifying possible symptoms of depression in the postnatal period. It has good internal consistency and good short-term test retest correlation. These are some of the questions. One, I have been able to laugh and see the funny things of life. I have looked forward and with enjoyment to things. What is important is that what we know now is that the scale should happen not after, but even before. So if we know that a mom is testing or is at risk or is elevated for depression, then we now can get that support connected to this mom and to that family before birth, which can, one, help with the bonding and also to minimize those symptoms by the time that baby is here. The perinatal anxiety screening scale, which is the PASS, it screens for a broad range of anxiety of symptoms during pregnancy and the postpartum period. It is a little bit longer. It is very long, actually. 31-item questionnaire. It is easy to complete and score. It is sensitive to how anxiety presents in perinatal women and may be used in a variety of settings. Even though Edinburgh is the gold standard, it is okay to always have a little supplement just to make sure that we are just checking all of our boxes and we are making sure that this is a comprehensive assessment. The scale assesses 4 categories of anxiety: acute anxiety and adjustment, general worry, and specific fears, perfectionism, which sometimes a woman may feel, especially when they bring the baby home, this control and trauma, and of course, social anxiety. And then finally, it constructs validity and test, retest, reliability, and support it. So with all of that, you get through all of this and you do the screening and you realize there's something is happening. There is support, this is the most important piece that moms and dads and everyone should take away, is that there is treatment and then there is support. It is an understanding. It understand the signs of symptoms, so you want to do it prenatally and postpartum. There's referrals to mental health professionals early, community-based resources, and to assess family and spiritual supports. Spiritual piece is very important. A lot of times, spiritual support was kind of taken out of mental health, but now it's really important that it should be assessed and included. And then we think about medications and management. So some of the treatment approaches, of course, is psychotherapy, just that one-on-one which can be individual and even in group as well. Cognitive behavior therapy, just to really reframe and really reframe and redefine and change thoughts. Meditation and mindfulness is really important, especially during that postpartum and even during. SBRT, the motivational interviewing, really, understanding like how do you want to be a mom? What makes you a good mom? Just really honing in, what does this person want? How does that person see themselves or want to see that person to themselves as a parent? There's also residential treatment programs with mommy and baby. Then, of course, there's couples, family therapy, which is very important because we know that when you add another little person, every relationship changes on so many different aspects. And then, of course, there's outpatient, inpatient, and then group and peer supports. And there are national resources. Maternal mental health hotline. Anyone can call, especially if we see someone in crisis. It has a cute little name, so you can't forget it. TLC Mama. So let's love on our mamas. But dads can call as well. And then there is Postpartum Support International, which is a global network of just support for moms, dads, families, even providers, and national child and national health education programs, and then finally, National Perinatal Association. And of course, the March of Dimes, which has historically been there, just supporting and helping families and moms, and Maternal Mental Health Leadership Alliance.
Mm-hmm. Can I add? We also included the American Psychological Association Perinatal Mental Health Toolkit, which can be accessed at this web link here. And there are a couple points that you made, Unique, that I want to reinforce, if you don't mind.
Of course.
That I thought are really important. And I want to make sure those are also takeaway points today. One is you talked about the impact of having mental health challenges such as depression, anxiety, or PTSD on mother's ability to show up in her parenting role. And this can really disrupt attachment bonds and have impact on parenting trajectory for months to come, years to come, because it's a very sensitive time to bond, to develop a bond with your child. And it really, again, sets the trajectory for future and long-term parenting patterns. And that is also a challenge with mental health. And it's why we want to understand, assess, know when mothers are having mental health challenges and get them the help that they need as soon as possible, because again, it will impact parenting trajectories long term. You also mentioned during COVID-19, the fear of losing their job. And it was a real fear at the time. And it's not always just about losing the job and having worried about able to take care of my family and take care of the bills, but also I may lose my health insurance during a time where I need to access my providers and my care, especially if I need mental health care and support. And I think those were 2 points that you brought up that I just wanted to make sure we reinforce those areas, because, it was related to COVID-19, but when we talk about employment and job security, it really has an impact or concern about whether I'm able to continue my prenatal care and my delivery. And will I be covered, or will I, have bills associated with that as well? So I thought that part was important. And I also just wanted to add, when we're thinking about stigma, you talked about some of the treatment as medication management. A lot of times mothers are not happy about or not motivated to take medication. Sometimes it's the symptoms telling them that. If I'm depressed, I'm not motivated. If I'm not motivated, I don't want to take my medication. But it's a challenging population to work with when it comes to medication management because of the fears of the medication on their unborn child. There are real fears that if I take this medication, something is going to happen to my child because of a side effect of the medication. And so we usually encourage mothers to work very closely with their OBGYNs, and the OBGYNs help with the education. So the assessment piece is important because we can determine whether there's a diagnosis there, but it's also important because, like you said, it's a touch point for education, and not just education about the disorder, but also education about the treatment options and their safety. And then there's again, and that's a concern not just prenatally, but it's also a concern postpartum too, especially for our lactating mothers. And we encourage that the mothers work closely with their pharmacists as well as their lactation consultant so that they're reassured that they can continue to breastfeed while getting the treatment that they need as well.
For sure.
Uh-huh. Did you want to add? I didn't want to cut you off, but those were some points you brought up that I wanted to read because I thought
Thank
they
you.
were very important.
Thank you, Professor Cross. No, I think so. I just even in the research that I've been doing, I think the most important thing is really whether it is therapy, whether it is medication, whether it is groups. I think it's just that women birthing persons should be able to just to know, so just to have those options, not to push anything on anyone, but just to know that you are in a space where this is normal. This is extremely normal. It's so normal that you can get help.
Mhm.
And there is help out there.
Mhm.
And you should know all of your options and then you pick accordingly with the information that were given to you.
That's a good point. And we want to use all options available, and not identify a specific course of action, right? Because there are some mothers that may feel more comfortable with the support group rather than seeing a therapist because of stigma sometimes. Sometimes they may want to talk to a spiritual advisor, or they want to lean more on their faith for additional support. All options should be looked at and incorporated into the plan of care. I agree. So I just want to take this time to close out. I want to thank everyone for being a part of our discussion and also include the evaluation for our presentation. There is a QR code on this final slide. If you can just pull out your phone, take a picture of it, and evaluate the presentation. If you are interested in just click a link, we've also included the link available here. It only takes a few minutes. Please provide us some feedback for this presentation, and we appreciate your time and your willingness to come listen to us again talk about a very important subject during Maternal Mental Health Month. And so thank you everyone for attending, and hope to see you again soon on an upcoming presentation.
Thank you again.